Kia ora katoa, haere mai, nau mai. Ko Dr. Richard Griffiths toku inua, no tamaki makaurau e titai tokarau oku tipuna, kei ti nohu au ki orauaka ti ahika a rakatura. Hello everyone and welcome. My name is Dr. Richard Griffiths and I'm the Research Manager at Arthritis New Zealand, Mate Pona Pona Aotearoa. I identify my ancestry as being from the Auckland and Northland areas, and I currently live in Mount Albert. Before I introduce our guest speaker tonight, I will share a short karakia. Mā te rongo ka mohio, mā te mohio ka marama, mā te marama ka mātau, mā te mātau ka ora. That translates to, from listening comes knowledge. From knowledge comes understanding. From understanding comes wisdom. From wisdom comes well-being. It is my absolute pleasure to welcome you all to the very first presentation of the newly established Arthritis New Zealand Mate Pona Pona Aotearoa Research Seminar Series. Going forward, this new series provides our organisation the opportunity to showcase the research and indeed the research teams that our organisation is funding to help improve the lives of people affected by arthritis in Aotearoa, New Zealand. Tonight's inaugural speaker is Dr. Daniel O'Brien. Daniel is a senior lecturer in the physiotherapy program at the Auckland University of Technology, or AUT, where he has taught for the past 15 years. His teaching and research interests include ACL injury, post-traumatic osteoarthritis, the management of chronic conditions affecting the musculoskeletal system, i.e. lower limb joint pain and OA, and the development and implementation of interprofessional clinical services and service delivery models. He is also a champion of bringing people who are patients or consumers into his research projects to enable them to share their lived experiences of osteoarthritis and MSK-related conditions. Daniel's research has led to the development and uptake of the Aotearoa Osteoarthritis Guidebook and the more recently published Aotearoa Osteoarthritis Booklet. He is also the chair of the Osteoarthritis Aotearoa New Zealand Summit Committee, a group of dedicated members from clinical practice, researchers from various universities, health service managers, and not-for-profit organisations. This group have hosted a number of conferences or summits over the past few years, which address concerns about the health system, responses to the growing burden of osteoarthritis in New Zealand, and the absence of a national model of care for managing the condition. Daniel enjoys going on long tramps in his free time and trying to keep up with his two daughters who love the great outdoors. Just before Daniel takes over, I'd just like to let you know that the webinar is being recorded and will be available on our various communication channels soon. And please, if you have any questions, feel free to put them in the Q&A function and we will answer as many of those towards the end of tonight's session. Thanks very much, Daniel.
Kia ora, Richard. That I'm sure is longer than the introduction that you asked me to send through, but thank you very much. That's very kind. I'm now going to do the most stressful part of the whole evening, which is making sure the technology works. So let's make sure we can get through to there. Now, Richard, I'm trusting that everybody can see this, so you can let me know if that's not the case. Thank you very much, obviously, for the invitation to come along and talk tonight. This really does feel like a little bit of a full circle moment because probably about 15 or 16 years ago, myself and Georgina Greville, who was an Arthritis New Zealand nurse educator, set up a series of education evenings here at the university, and we ran it for about 5 years. And so my job was really to do what Richard has just done and do the introduction, and then I'd get to step back. So when Richard approached me last year and said, we'd love to hear about what you're doing, I felt like, given that a lot of what I've done over the years has been about trying to bring research to people, I thought I had to come and take this opportunity. I'm going to be talking about a few different projects that we've been involved with in recent years. And just to reiterate that while I'm the person standing here in my office at AUT presenting it, there's a whole team that has gone into all of these projects and just acknowledging their work. So you'll see their names pop up as we go through some of the different slides. The other thing that I just wanted to say was a couple of other things I was going to mention before we kick off. One is that the invitation was to come and talk about research we're doing and present some of the research that we're involved with, or some of the research that has informed how we're practicing and what we're doing. But I'm mindful that I don't want to make this too much of a researchy talk for a couple of reasons. I think it's really important that knowledge is, transferred or translated in a way that people can use it. The other reason, which is probably a bit more of a personal one, is I'm not very good at talking as a researcher, so I feel much more comfortable talking as I would to patients or friends and family about these sorts of things. The other thing to be mindful of is we are focusing on knee injuries, and a lot of today we'll talk about, or this evening we'll talk about ACL injuries, which is a specific injury. But a lot of the things that we talk about today are really, really relevant for osteoarthritis or post-traumatic osteoarthritis of any joint. So without further delay, we'll push on. And again, I'll just see if we can get the computer working. As Richard just said, I try and do a few other things, and a couple of these pictures will become relevant as you see my presentation. Like Richard, I live in Tamaki Makaurau up here in Auckland. My wife and I have two now teenage daughters who are quite tricky to keep up with. The picture on the top right-hand side is of Izzy and I, my eldest daughter, doing a trail run last year. And the irony of that photo is that was about halfway through the run, and that was the very last time I actually saw her on the run, because we hit a hill and she said, "I'll see you at the end, Dad," and I never saw her again. Outside of work, the other thing I love doing is tramping, and a couple of weeks ago I got to take a couple of researchers from Australia, or one from Australia and one from the UK, tramping. I was told very strictly, because the tramp was before the conference we were running, not to kill the researchers. We didn't. I think I managed to give them a good appreciation of the South Island and what it holds. And the other thing that I like to do when I'm not out in the outdoors or with the kids or at work is playing music, and have done so for about 30 years. So that's a little bit about me and a little bit of context. And you'll see some of this context come into the presentation tonight. Oh, it looks like my computer is going to be funny with the slides. Anyway, there we go. So there's really four things that we want to get to at the end of today, or four questions. One is, what is the connection between ACL injury or this knee injury and post-traumatic OA? What is this notion of lifespan approach? And what's the relevance of that to osteoarthritis? What does high-value osteoarthritis care look like? And why should we be focusing on PTOA or post-traumatic OA in New Zealand? So for me, the very first time I heard about ACL injuries actually was when this fellow on the top left-hand side of your screen, he wasn't a Sir back then, but he's now Sir Michael Jones, did the injury. And speaking to colleagues who are involved in the rehab, and actually having spoken to him as well, he didn't just break one ligament. I think he broke about three, and the impacts of that were huge. But I remember that as a kid. A couple of years ago, when we were first kicking off this research, we were hosting in New Zealand, Australia, the Women's World Cup. And there were several articles about the ACL club. And this is this notion that so many players, particularly women players, were missing out on participation in football, and in particular the World Cup. I think there was like 21 players missing the World Cup because of ACL injury. So it's a big problem. And the final picture actually just came from RNZ. I think it was last weekend that I saw it. And again, just listing all of these injuries that come out of sports, particularly rugby. Now, some people will say, well, there's an easy way around that. You just don't play rugby. Clearly, that's not going to work. You know, there is huge benefits participating in sport. And I don't want anyone to get to the end of this presentation and think the easy way to deal with this is just not play sport or not be physically active. The negative effects of not being physically active well outweigh the benefits or the relative low risk of injury. Ironically, every time I injure myself, and I sprained my ankle about 3 weeks ago and turned up to work saying, well, that was my fault, I shouldn't have been doing exercise is bad for you. I only say that tongue in cheek because really, to steal a quote that a sports doctor I know well uses, he always says, if I could take the benefits of exercise and physical activity and put it into a pill, I'd be a millionaire. I'd be a billionaire. So don't take this presentation as a sense of avoiding exercise or physical activity, because we definitely don't want that to happen. Why do we worry about osteoarthritis in New Zealand? Because it's really, really expensive. It affects a huge number of people, and it generally affects people disproportionately. So there's inequity around it. These are relatively old stats these days, but we are still talking about hundreds of millions of dollars. And when you look at the bigger impact and the wider societal impact, we're talking about absolutely billions of dollars now. I was chatting with a colleague in America about 3 weeks ago, and she was saying that musculoskeletal or long-term musculoskeletal conditions are now their biggest concern in America, or at least in the state where she is based. Because it has such a massive impact, and particularly because a lot of these conditions or injuries or whatnot affect us while we're still working age. So it has economic impacts as well. The other reason and the reason I got into osteoarthritis research about 15 or 16 years ago is because I think we can do better in New Zealand. And I can't online share the original title of this article we were going to write a couple of years ago for the New Zealand GP journal. But I think the take-home message of most people waiting for osteoarthritis care in New Zealand don't get it pretty much sums up what we were trying to say. So as clinicians and researchers, we felt that it can be done better. So I suppose that's some of the bias that I bring into this space. What is a lifespan approach to osteoarthritis, and what do I mean by it? Well, I suppose the key thing, and probably the key bias to get out in front of people early on, and the thing that definitely confronted me when I was first diagnosed with osteoarthritis, was this notion of it being an old person's disease. And I wrote an article with a few friends of mine a few years ago, basically listing the myths for osteoarthritis. And the big one that we put up right at the front was that it's an old person's disease. We know that it's not. I know that it's not personally. So I've had many injuries. These are just some of the highlights, so to speak. And the first time I connected osteoarthritis with me was when I had to have shoulder surgery when I was about 20. So I dislocated my shoulder playing rugby when I was 16. It got gradually worse and worse and continued to slip out of joint. And by 20, it was really problematic. I was at physio school. They were saying you're not safe to move patients around with a shoulder that keeps slipping out like that. And so you're going to go for surgery. And the surgeon told me after I'd come back following the operation that by 30, I would have osteoarthritis in the joint. I never thought of 30-year-olds as being somebody who had osteoarthritis. Now, the absolute irony of that is I was back in the same clinic a few years later with another injury, this time with regard to my foot. And the sports doctor was looking at the x-ray going, oh, look, I can completely see what the problem is. You've got severe osteoarthritis in your right foot, in your right big toe. And then he looked at me and went, oh, actually, your pain's in your left foot. Just ignore that. And so I was officially diagnosed with osteoarthritis at 25, even though I didn't have any pain in the joint at that stage. So my experience is backed up by a lot of research. And there's a really cool study that came out of Canada a few years ago. And so, as you can see, they surveyed just under 1,800 people. So these were people with only osteoarthritis as a diagnosis. They didn't have ankylosing spondylitis, rheumatoid arthritis, or anything like that. And as you can see, over half of these people were under the age of 65. Now, many clinical trials in osteoarthritis don't start including people until they're 65. So that in itself is quite a meaningful thing. Most, or at least half, I should say, were diagnosed by 50, and a third were diagnosed by 45. So again, that would fit in, I'd fit into that category. The other thing that was really interesting from this study is what they said is that there was no meaningful difference in the symptoms for somebody who had osteoarthritis and was young versus somebody who had osteoarthritis and was old. So I thought that was really fascinating. So the burden isn't necessarily, worse as you get older, which is kind of a good thing to know as I am getting older. So why me? Why am I in my mid-40s and having osteoarthritis, having been diagnosed over 20 years ago now? Well, if we look into the risk factors, that tells us a little bit of a story. So we'll just highlight the risk factors that link to me. So in terms of genetics, my dad's side of the family, the standard joke is no O'Brien runs beyond 40. That picture shows that I've managed to bust that myth in our family. Admittedly, I don't run well beyond 40, but I do manage to run. I've had multiple joint injuries, as you know. Sadly, I am getting older. I am a little bit overweight, as my GP likes to remind me. I am an academic, which means I spend most of my days sitting at a computer, or in this case, standing at a computer. And I'm sure my diet and sleep habits could be better. I mean, my dinner tonight was a cookie time cookie, which is probably far from ideal. And for a long time, I had the idea or the mentality that you can sleep when you're dead. As I'm getting older, I'm starting to change those behaviors. But there are a lot of factors within there that, as I say, make me or raise my risk profile for having osteoarthritis. So in terms of management, most of the funding, care, focus, research, all focuses on what's on the right-hand side of your screen. Yet there are lots of things that can be done in other elements of it. When I talk to key researchers internationally about funding for osteoarthritis management, they say you should spend most of your money before the person turns 20. If you can keep them physically active, excited about exercise and physical activity, if you can put them in an environment that allows them to manage their weight well, you can introduce injury prevention programs. These things make a massive difference to the likelihood that people will go on to develop osteoarthritis in the future. But like everywhere else, or most other places in the world, most of the funding and focus sits in that right-hand side. And as I sort of alluded, we should be doing everything. So if you're thinking about a lifespan approach, and I really pick on physios when I say this, as physiotherapists, we can do most of those things, and we should be in our clinical practice. If a sports physio says to me, look, I only deal with athletes and sports people and young people, I don't have to worry about osteoarthritis, I've challenged them about that very, 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 very strongly, shall we say. In terms of what's the best evidence and where high value care sits, it's the same things that typically come up over and over and over and over again. It doesn't matter which guideline you look at. This comes out of, what we've got on the left-hand side of the screen is a combination of the UK NICE guidelines, the International OA Research Society, European and the American guidelines. They all pretty much say the same thing. Knowing about your condition or the condition is paramount. Knowing what it is, what you can do about it, how it manifests, on and so forth. Being physically active. I think I've moved away from talking about exercise, because for some people, exercise is a bit of a dirty word. They don't like the idea of that. But being physically active, getting out and doing walking, dancing, whatever it is that you like is a key thing. Weight management is tricky. We all know that. We're seeing the explosion of weight management drugs coming onto the scene at the moment. I think that will have a significant impact on osteoarthritis as well as many other conditions, but they do come with side effects. So it is going to be interesting to see how that plays out. But for many people who are overweight with osteoarthritis, losing a small amount of weight, and typically we say, just start with 5 kilos, which isn't easy, I must admit. We know that will have a significant change in joint pain for people. So we know that works. And the other thing that we know that works really, really well actually is joint replacement surgery. But there's a caveat to that. It works really well for the right person at the right time, and done in the right context and environment. Most people with knee osteoarthritis will never actually need a knee joint replacement in their life. It's less than 20% who will actually need it. So it's not the sequelae. It's not the thing that you're going to have to work towards or see in your horizon as an inevitable thing. For anyone who wants to look at some of the resources that Richard alluded to at the start, that QR code does bring it through to the guidebook, and you're more than welcome to have a look at that. That image comes from it. That said, all of these resources will be available to people who've registered for the webinar later as well. So don't feel like you have to chase around and try and capture the QR code. So why do I care about post-traumatic osteoarthritis? I think I alluded to it a little bit before when I was talking about that notion of a lifespan approach to managing the condition. If we deal with it early, if we deal with it earlier than 65, when we're kind of trying to be the ambulance at the bottom of the cliff, we're going to save money for the health system. We're going to reduce the impact of the condition on people and of joint injuries on people, and we're going to improve people's quality of life, which for me is a key thing. So to put it in a different context, and I'm going to pick on my daughter here, she's going to hate me for this, but let's just imagine that this year she ruptures her ACL, so damages that ligament in her knee that I was talking about before, while she's playing netball. Now, unfortunately, this analogy doesn't work as well as it did a couple of weeks ago, because yesterday she told me she's not playing netball this year. But let's say she does. And we know she'll miss 12 months of her sport. That's regardless of whether she has surgery or not. There'll be a long period of rehabilitation. It may impact her schooling. It'll definitely impact her socialization with her friends. We know that it might impact her mental health. And we've seen that come through some of the studies I'm going to present shortly. 10 years down the track, she will probably start to have structural changes in that joint. She might not have any symptoms. She might have symptoms, but chances are she won't. But we know that if we were to do an MRI or something like that of the knee, it wouldn't look the same. Fast forward a few more years, and she's now in her 30s. Chances are she's going to be, juggling work. She might be juggling a family, which is a scary thought for me right now because it makes me a grandfather. Chances are her knee will be starting to give her trouble by that stage. And again, that's what we've heard from people we've spoken to, and that's what the research data shows. By the time she's in the 40s, there's a very good chance it will be impacting her quality of life. It might be impacting her work. It may be impacting her ability to stay physically active, etc. So that's with poor management. We're hoping that with some of the programs and the research we're doing, we're going to be able to support people to make good calls around this. And you could look at the need for joint replacement in their 50s and go, well, that seems a little bit far-fetched. But a couple of weeks ago, I was having a beer with a friend of mine who I used to work with when he was an athlete 20 years ago, 25 years ago, when I was working with his team. He's a little bit older than me, but only just, and has already had a knee joint replacement as a consequence of these injuries. And we've spoken to several people as part of the study who have ended up with knee joint replacements in their 40s. So it is definitely something that we want to avoid, and we'll talk a little bit more about how. So as part of kind of exploring this problem, we had a look at what was happening elsewhere. And there are quite a few programs that are happening. When we first started looking at this 3 years ago, or about 3 years ago, the main one that was running was the one that Jackie was leading out of Canada, which is the SOAR program, which is the two articles on the left-hand side. And while it would have seemed really nice to be able to take that SOAR program, pick it up and drop it into the New Zealand context, we knew that we couldn't do that because we know taking something from a different environment generally doesn't translate well to New Zealand. So we set up this program of research, which is what we've got here with a series of studies to go, well, what do people need to know in New Zealand, or what do they want? What's the context? What are some of the other things that we could do? We wanted to understand the New Zealand environment so that we could look at solutions that work here for New Zealanders with knee injuries. So the first thing we did is it seems really obvious. We did the first phase of our work, and that was to go out and talk to people and see what they thought. So we spoke to 12 people, if I remember rightly, who had had knee injuries. Now, some of them had had knee injuries or had ACL injuries and ended up having surgery 5 years ago. Some of them, or I think it was 6 was the minimum, some of them had had the injury 30 years ago. Most, or just over half were women. The age range was big, which was great because we got lots of different experiences. We had a mix of ethnicities. And the COOS score is a knee quality score, a knee quality of life score. And the lower the score, the less you can do, is basically the easiest way to understand it. So we spoke to people, 54 is quite low. And so we spoke to people who were really looking at a knee joint replacement as a solution for their knee pain, and they were only in their 40s. And we spoke to some people who were doing incredibly well and running ultramarathons and things like that. So really high level of function through to people who are more affected by it. And what we did is we took all of these stories, and I won't bore with the details of qualitative research, but we sifted out some of the key points that were being raised. Sometimes they were points raised over and over again, or ones that really stood out and connected with the others. And so there were 3 themes that we constructed from that data. One was this notion that nobody ever told me. And there was a strong belief that for many people prior to having surgery, that they'd have surgery and their knee would be fixed. For anyone who's had joint surgery like myself, you know it's a lot better after the surgery generally. I'm still thankful I had my shoulder reconstructed, but it's never been the same, and it never will be. So it was this sense of not getting enough information beforehand of what was going to happen afterwards. The other things people talked about was this post-rehabilitation void. So they would have a period of rehab after they had their injury or their injury and their surgery. But then when the ACC funding ran out, there was nothing else. There was nothing else in the system. And for this fellow, he was desperate to get back to see somebody, but there was no ACC funding, and his GP didn't want to send him to orthopedics. I suspect because she knew orthopedics would have turned down the referral because he was in his 30s at the time. The other thing that really stood out to us was the psychological impact. So while only one person that we spoke to actually used the term mental health, everyone we spoke to talked about how it had shifted their psychological well-being or their social well-being, and we've seen that in other areas as well. And one of the things I find really interesting, and it resonates with me, is I can tell you all of the things that happened when I dislocated my shoulder like it was yesterday. People never forget that moment of injury because it sticks with them for such a long time. And that kind of speaks to that notion of, it happens in seconds, but it lasts forever. It's always there for them, whether it's physically or psychologically, or often there for them, I should say. So next we wanted to go out and speak to people in the wider ecosystem. And as you can probably see, our team started to grow. So Josie joined us. And we reached out to clinicians because that was easy. We reached out to funders like ACC, advocacy groups, etc. But more importantly, we actually reached out to other support people, spoke to parents, which was a big one and a really interesting one. And also we spoke to the coaches. And for me, the parents and the coaches were the most interesting people to speak to, but also the hardest people to speak to, because they gave us a very real insight into what it is like for these sorts of people. And it is challenging. These, for one, if I can share one story, was a participant who we interviewed, and her daughter, who was 16, if I remember rightly, had ruptured her ACL twice in the space of 12 months. Mad keen netballer. Netball was her life, and she now was looking at another 12 months of rehab, having only just been through it once before. So the impact on that young woman's mental health, physical health, social identity was huge, and that impact carried on to her mother as well, and the wider family. In terms of themes, things that are standing out to us in the data, and we're just finishing the analysis of that, is this notion that, we've got to think about a knee for life. The injury happens, the rehab happens, but you want to plan for, as one surgeon I spoke to said, future me, future knee. What's the knee you want to have in 15, 20 years' time? There was this sense of blaming, and ACC comes up a lot, but it was interesting. Most of the people we spoke to said, we think ACC gets blamed unfairly, and that actually it's a bigger thing that we need to be looking at. There's more stakeholders in terms of the Ministry of Health and whatnot that need to feed in. Another point that was raised was the notion that it's an athlete's injury only. And so this was an interesting concept, because everybody was sort of focusing on this return to sport. Yet we know that probably on average for an anterior cruciate injury, only about 50% of people will get back to, or will choose to go back to playing that sport. So we need to make sure that there is management and planning for people who decide, like me, I don't want to go back and play rugby again because that surgery hurt. I've done my time. The other thing that came up was this notion that we need to, as healthcare professionals, think more about community engagement. Are we working with the parents? Are we working, with the coaches, etc., to really provide an environment for these people to do well following their injury? So that was a really useful piece of work. We then had the opportunity to work with Wellington Rugby, and I'll just bring this forward. So we did a survey. We piloted it this last year, and we sent it out to people who are on the Wellington Rugby membership to ask them about how their knee injury, or had they had a knee injury, and if they had, would they be happy to participate in our survey. The return rate was a bit low. Well, it was probably very low, but it's fair to say I think a lot of people get inundated with surveys and things like that these days. So we were happy as a pilot exercise to capture information from about 100 people. And it was interesting that the story, and I won't talk to all the data, but the story that it shows is kind of what we already know. So most of these people who have these injuries are young, under 25. Nearly 40% of them are really young, so under sort of between 19 and 16. About half of them got back to full participation in sport, which I just mentioned. The thing that I thought was interesting was only 40% described themselves as satisfied or very satisfied. So that would suggest that 60% weren't satisfied. So that was kind of knee injuries more generically. We asked some of the people, or we asked everyone if they had, believe they had OA, to answer a couple of other questions. And again, I won't talk about all of the data, but there's a couple of points I think that is interesting. And bear in mind, this was only about 40 or 50 people, so it's a much smaller group. But still 60%, or nearly 60%, they said they'd had no conversation about OA, even though they thought they had it with a healthcare professional. And 60% said it had some impact on their mental health and wellness, which again just speaks to what we'd seen in some of those other situations. So we came out of this thinking the survey tool worked. We tested it pretty rigorously. It was a bit of a trial. Wellington Rugby has connected us with RNZ, so Rugby New Zealand, and we're going to roll it out nationally this year. We're also looking at working with other codes, so particularly netball. I think touch rugby's coming on board, and we're hopefully going to get basketball New Zealand, because we want to get a sense of how big is the problem, and are the things that we've seen from the pilot data, do they roll into everything else as well? So the next piece of work that's still underway, but I will talk about a little bit more, and as you can see, our team keeps growing with this. We got funding from HRC, which is the Health Research Council, to run a series of HUI, or a series of workshops around the country, to find out what people think would be a good solution for this. How do we help people who have had significant knee injuries manage them well, so they're not needing a knee joint replacement, in their 40s or early 50s. So I won't talk through the methodology of this too much, but really to say we all got in the room for 3 of these workshops, and in one of the HUI we ran online, and we gave people different scenarios. So we said, well, here is an example of somebody who's, and they were real case studies, somebody's had an injury. What we want you to do is think about what are some of the problems, what are some of the solutions, where could we go with this? I'll just skip the slide because you don't need to see a map of New Zealand. And we got them to put it all on post-it notes. And then we said, okay, now imagine this person is now 10 years older. So they were 18, they're now 28. And then we did it again, they're now 38. And we did this a few times to start getting them to think about, where is the person's trajectory and what are some of the solutions that might kick in over time. So that's just a bit of an explanation of what I've just described. Unfortunately, we don't have any answers to phase 5 yet, to phase 4, because we're still looking at that data. But I was brainstorming, or sort of reflecting on all of the information and stories that we've heard over the last 2 or 3 years with this project, and pulled out a few things that I think is the direction we're going to be heading. So one of the key things that we've heard is this notion of demedicalizing support. Support for people when they've had a significant injury like this, and support going forward. An element is the medical care they receive or the rehabilitation, but that's a relatively small part. We need to think about who else is in their environment that can help them and work with that. We've looked at what comes next, and there's a few things that I think would be quite exciting. One is we need to look at ways to better engage the social and mental well-being of these injuries, and I think that starts right at the right from the time of that injury and when they start rehabilitation. So this might be greater access to psychologists, for example, for people who are struggling with mental health issues as a consequence of their injury. Greater awareness of the impact it has on your mental health as well. So there's things that we think we can do around there. One of the things I'd really love to do is work with coaches and PE teachers and people who are working with young people in particular when they have these injuries, not only to help highlight the importance of the rehabilitation, but also to give them a license to say, look, please keep these people in your team. They may not be on the field or the court or whatever. Get them coming along to training, get them helping out, carrying the water bottles, make sure that they feel part of that team, because that's really, really important for their mental health. And that came through from one of the studies. The final thing, or the final sort of option that we'd like to explore, and hopefully we will later this year, is this notion of tiers of management. So not one thing is going to help everyone. It may be that a well-curated website, or maybe something with a chat bot, and I'll talk about that in a second, might be all you need to get the inspiration or the information that you need to manage your knee or your hip or whatever the joint it is. But also we think that there's the opportunity to explore some of the work like they're doing in Canada to run booster sessions, which might be 4 weeks of fairly interactive sessions with a physio or a dietitian or a health coach or something like that, to give you confidence that you can feel like you're getting on with doing exercise. But I want to come back to the AI thing just for a second. It's very, very popular at the moment. I am intrigued by AI. And so I've started playing around with it a little bit in terms of joint pain. And just a disclaimer, AI is not your GP, so please don't think about it that way, but it is an interesting tool that we can use. So I asked AI a couple of, this was ChatGPT, I asked it a couple of questions about ACL injuries. And when I read the answer, it was actually pretty good. In most cases, it was something that I would happily present to a patient in terms of managing their condition following, knee injury. I thought, well, that's all well known. There's lots of information in the internet around that. Clearly, that's an easy question for AI. So I challenged it a little bit around the mental health. And what I was quite surprised about was the fact that I think it actually might have been a little bit more empathetic than I would have been as a clinician. So I was really pleasantly surprised, and it had some really good suggestions that came out. So again, a disclaimer: AI is not your GP, but I think there's some pretty interesting opportunities that are going to be available to us in coming years. So coming back to our sort of questions at the start, just to reiterate, OA is not just an old person's disease. So if you've had a joint injury, you've just been diagnosed with post-traumatic OA, or you suspect that you might have it, it doesn't mean you're old. It doesn't mean you're on the scrap heap. Many people in their 20s are diagnosed with this condition. Thinking about it as a lifespan approach, I think, is fundamentally the way we need to tackle it as a health system, because it will decrease the burden long term and allow us to live better with the condition, and I include me in that. We need to focus on funding what works from a healthcare perspective and getting it into systems and making sure those systems are working for people. And fundamentally, I think we need to focus on post-traumatic OA because, if you're like me, diagnosed with OA at 25, chances are I'm going to live to 85, fingers crossed. So that's 60 years to live with a condition. So I want to make sure those 60 years are as good as I can possibly make them. Well, now that I'm 46, it's another 40 years. But again, I want to be still tramping into my 70s and 80s if I can. That might be a bit wishful thinking. So if you're sitting there and going, well, that research is nice, but what does that mean for me? What can I be doing right now to try and improve my joint health and increase the likelihood that I'm not going to need joint replacement surgery early or potentially at all. We'll take out the things we can't really change. If you've already injured yourself, we'll take that off the list. We're all going to get older. Sex, we can't control, and genetics, we get what we get. But if we look at the things that we can change, I know I've heard a saying that it's easier to quit heroin than it is to lose weight. I don't know if I agree about that. I can't comment, but losing weight is really, really tough. So it is something that needs to be done with support and help. One of the things that somebody was saying to me, and again, easier to say, but as we get older, we inherently put on weight. That is just kind of what our bodies often do. Partly it's a societal thing. If we can manage it as we get older, that's going to set us up a lot better for the future. To steal a saying from a friend of mine, Rebecca, she always talks about the best exercise is the next exercise. So there is no perfect exercise for managing joint pain. Generally speaking, it's the one you like doing and the one that doesn't stir you up. And there's a bit of negotiation around that. That takes a bit of practice. This is a saying I stole from, I think his name is Michael Pollan. He's a journalist and health writer or food writer. And he always talks about eating food, i.e. food your grandmother would recognize, mostly eating plants and not eating too much. And I think there's thousands of dietary recommendations out there that you can look at. For me, that's one of the best ones. There is some really cool studies coming out of the Netherlands that are looking at plant-based diets for joint pain, and it's showing some really cool research, but that's a whole nother topic, and I'll leave that for someone more qualified than me. The final one for me that has really had the biggest impact, I think, is sleep. and it's something that nobody ever taught me about when I was studying physiotherapy at undergraduate or postgraduate. But there is more and more research showing that one of the best things that we can do for our inflammatory systems and joint pain is focus on sleep hygiene. Again, that's another talk for another day, but definitely something to work in. And my final comment in this space is really just don't try and change everything. If you're like me, you're middle-aged, you're thinking, great, I want to be physically active for another 20, 30 or 40 years, just pick one or two things that you can do to change your lifestyle. It might be looking at portion control with your eating. It might be going, all right, I'm going to be a bit better at going to bed at a regular time. I'm going to be a bit better at getting up in the morning and going for a walk before I go to work or something like that. But just pick one. Don't try and do all of them at one time. It never works. And so as a final thing, do I think we can reduce the burden of osteoarthritis and knee injuries? Quite clearly, I do. If you do want to know more about the guidebook that we've created, and we've created a couple of them now, or we've got another two in the pipeline, that the QR code in the middle can take you there. But we'll also, as I say, make some presenter notes that you guys will get as part of being part of the webinar. And if you're interested in being part of the research we're doing in this space, and you don't have to be in Auckland for this work, you can be anywhere in Aotearoa, New Zealand, feel free to scan the QR code on the left. There's a few little questions there you can fill out that sends your contact email to us. And if we've got projects, or when we've got projects coming up, we can reach out and contact you about that. So that's it for me, and thank you very much for giving up your night tonight and being part of this. A little bit of time for questions if you get to grill me.
Yes, absolutely. Yeah, so we've had quite a few questions come in. Thank you everyone who has put those in the Q&A and also the chat. I don't think we're going to be able to cover everything off, but we'll give it a crack.
Give it a go. Yep.
Yeah, so the first question, is there a typical period of time from injury to OA presenting symptoms?
That's a really good question. It's a really easy one to answer, and unfortunately the answer is probably not very satisfying. No. So we've seen people start to develop OA symptoms potentially within 2 or 3 years. And then we've seen people not develop symptoms for, 20 or 30 years. So as the fellow that I talked about, who we'd interviewed 30 years after he'd had surgery, and he actually he injured both his knees. He was a football player. He was in his 60s and still playing football. So he definitely had OA changes, but he was doing really, really well. And he'd been symptom free for quite a long time. One person we interviewed, and it was 25 years since she'd done the injury, and she was completely symptom free. So she was the absolute extreme end. And she was a teenager when she did it. It was a netball injury. So no, there's no hard and fast rule. The more we learn about it,
to think that it's just different for everyone. Everyone's experiences are different in this sort of space when it comes to these sorts of injuries.
Yeah, I mean, if you think about that list of risk factors, that's still not even all of them. And, we've all got different risk profiles. And so, yeah, it is quite different.
Okay, thank you. Right, the next question. Is there any research to suggest there's a certain age you should be before you look at surgery as an option?
There are studies that have looked at that, and I think it's about finding the happy middle ground. So I'll use an example of a friend of mine whose mum came to me and wanted some advice around it. So she was at the time in her early 60s, very, very physically active, but the hip OA was stopping her sleeping, stopping her at work. And she had the mentality that I just need to wait until I can't do anything. The conversation I was having with her was, well, this is significantly impacting your quality of life. your physical activity is dropping away rapidly. If you wait another 12 months, the outcome of surgery will probably be worse because you've got to that point. The other example I always use, and he probably hates me doing it, is my uncle who came to me and said, "Oh, it's I need a knee joint replacement." He was in his 50s. I said, "Look, now go talk to a specialist who I know. He'll give you some good advice. But from me, I reckon you just get back on your bike and lose some weight." I said that rather bluntly because he is my uncle. I also sent him to a surgeon who I knew would say exactly the same thing. And yeah, he did lose a little bit of weight. He has subsequently had a knee surgery, so he has had a hemiarthroplasty, but that was 15 years after he first asked for it. So it's tricky. There's no set time, but it's a bit of a window that works best.
Sure. Okay. Thank you. Next question's a little long, but we'll get through it. We developed and delivered a program on behalf of Te Whatu Ora Health New Zealand last year that was hugely successful in line with contemporary research and your talk. Problem is, with the change in government funding, canned what we can do to continue healthcare decision makers to fund an investment.
So what's the question?
Yeah.
What can we do to change health? I'm only smiling because my brain's going, I think I probably know, there's probably a handful of people who that could be, and I know them all. So probably the biggest frustration I've had in this space has been exactly that. So the last government launched a musculoskeletal pathway that was going to be an end-to-end care for people with joint pain. It was going to, or it does, because it still exists, include primary care solutions, options for people to see, physios in the community amongst that, as well as other people's, as well as pathways and effective pathways into hospital care and surgical care if people needed it. Why is the current government not funding it? I guess I just need, Richard, you and I need to make more noise.
Advocacy.
Advocacy, yeah. And maybe just vote them out. No, I shouldn't say, I'm not going to say that. I'll get in trouble for saying that. Yeah.
Okay. I think we've got time for maybe one or two more. So the next one is, I had a full knee dislocation when I was 18. I have significant OA with large multiple loose bodies in the knee. Am I doing any more harm to continue as I am without having more surgery? Have been told I am up for replacement. I remain pain-free, providing I continue with exercising on a daily basis.
That's a great question. I really like that one. I think that's an easy one. A joint replacement is for pain. So it's not going to, generally for many people, it won't increase your range of motion or flexibility or whatnot around the joint. So if you can do everything you want to do and you're having your quality of life and your pain is under control with exercise, I would stay well away from a surgeon right now. If things change, if it starts stopping you sleeping, you can't do your function, you can't, engage in your role in life. And I always think about, I speak to people, they often talk about struggling to connect with, do activities with their partners or with their kids or grandkids. That becomes a different conversation. But for now, I would say if you don't need a surgeon, stay away from the surgeon. You're not doing yourself any more harm at this point in time. Okay. And I'm basing that having not seen x-rays or not assessed anyone, but generally that's what people would say.
Okay. I'm just wondering, are there any differences in terms of men, women, ethnic groups, anything like that in terms of developing OA after ACL injury? Is there any sort of comment you can make on that?
So yes and no. So we'll talk about the sex thing first, and then I can touch on some of the ethnic stuff that we've seen from a New Zealand context. Up until sort of 40s, early 50s, so up until menopause, there isn't a big difference. Once you get past menopause for women, you are 2 to 3 times more likely to develop osteoarthritis than men. There's lots of different reasons for that. I'm not a women's health expert or an endocrinologist, but there's a massive hormone driver. And one of the things that I understand is that estrogen is an anti-inflammatory hormone in our body. So from a gender perspective, from a sex perspective, the burden, particularly as we get older, well and truly sits with women. And so we need to make sure that we're doing research that sits in that space. And as you know, there's some really cool researchers who are doing that in New Zealand at the moment. Coming back to the ethnicity thing, in terms of osteoarthritis itself, not really. I haven't seen anything that suggests that any one ethnicity is more prone to osteoarthritis than others. It's very different from something like gout, as we know. But if you, from our study stuff and in the context of New Zealand, we have lots of, and particularly in Auckland, Pacific Islanders playing contact sport, and I include netball when I say contact sport, that puts you at really high risk of having these injuries. So we do know that probably Māori and Pacifica, but particularly in Auckland Pacifica, are disproportionately affected by these injuries. And so again, it's really important that the research partners with these communities to make sure that we're doing what's right by those communities in terms of developing services and stuff. So for sex, yes, big discrepancy. For ethnicity, it's more around, the risk factors and appropriate, healthcare and rehabilitation.
Right. Okay. Thank you for that.
That's all right.
Yeah. So we've only got a few more minutes left. Just in interest of time, I just want to acknowledge that there's been a lot of people sharing their personal stories of injuries and OA and other sort of things that are connected to what Daniel has been speaking about tonight. So we thank you very warmly for sharing those, and we'll come back when we can with some answers to those other questions. So I'd just like to finish off now by saying thank you so much again to everyone who has joined us this evening. Please do keep an eye out for our next research webinar, which will happen a little bit later on in the year. We'd love you to join us again. We'll be doing them regularly throughout the year. I'd just like to close with a karakia, and hope everyone has a great night ahead of them. Ki tau te manakitanga, ki runga ki tina o tātou, kia piki te ora, kia piki te maramatanga, kia hoki pai atu, kia hoki pai mai. Tuturu whakamaua ki tina, hau mai hue taiki. And that means settle the core and protection upon each of us. May the health and understanding grow, return well to others and ourselves, hold fast to your authenticity, be firm, be united in purpose. Thanks again, and look forward to seeing you sometime soon. Thank you, Daniel.